Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Daiichi Sankyo Europe.
Welcome. Hello. I'm Dr. Vivek Subbiah, Professor of Medicine and of Pediatrics in the Division of Oncology at Stanford University School of Medicine. Also the Associate Director for Drug Development and Precision Oncology in Stanford Cancer Institute, and the Executive Medical Director of Novel Therapies and Clinical Trial Network in Stanford Healthcare, based in Palo Alto, USA. Welcome to this Medscape program titled Shaping the Future of Precision Oncology, Biomarker-Driven Care for Tumor-Agnostic Therapies. I'm very pleased to be joined today by Dr. Benedict Westphalen, Chair of the ESMO Precision Oncology and Taxonomy Committee and the clinical lead of the Precision Oncology program in the Center for Personalized Medicine in the University of Munich, based in Munich, Germany. Welcome, Benedict.
My pleasure to be here, Vivek.
This is a Medscape Quickfire, which means we'll have just 30, 45, 60, and 90, and sometimes 120 seconds to answer each other's questions on tumor-agnostic therapies. Great. So let's get started with the first question. Benedict, what are tumor-agnostic therapies? You have 45 seconds to answer this.
Oh my God, I feel so pressured. So in contrast to classical oncological therapies, tumor-agnostic therapies are based on a shared biomarker that serves as the therapeutic target. So instead of talking about a lung cancer, or colorectal cancer, or whatsoever, we're talking about a biomarker positive cancer, and this biomarker is a therapeutic target that we can then address. And the activity of our therapeutic intervention is comparable across these different tumor entities.
Finished in time. On to the next question. What is the rationale of developing these type of drugs, and how do they differ from our traditional cancer therapies? Would 60 seconds be enough for you here, Ben?
I'll try my best. So instead of starting with a given histology, let's say again, lung cancer, and you develop a drug based on specific features of a given malignancy, you start with finding and defining a molecular target, and you tailor your therapeutic intervention to that molecular target. And then during the drug development and clinical trial process, you observe activity not in just one or two, but in many cancer types. And if this activity then is seen across a broad spectrum of cancers within the drug development cycle, our partners in the industry might decide to develop this in a tumor-agnostic fashion. And then if the trials succeed, we have a new targeted agent that is tumor-agnostically approved.
Thank you for that great, wonderful explanation. Now, why are tumor-agnostic drugs an important treatment option? 45 seconds again here.
So this is difficult, and I'll try my best. So obviously expanding our toolkit, our drugs at hand, across cancers is always good. So tumor-agnostic therapeutics are another option. But often, for example, in rare cancers and hard-to-treat cancers, molecularly targeted options are scarce or nearly absent. And running clinical trials in these cancers is often difficult. So if you actually find and define a tumor-agnostic therapeutic, it opens up options in cancers and for patients that usually lack good therapeutic options, especially in the molecularly guided treatment field.
Thank you for explaining how important these treatments are for patients. Ben, could you please tell us what tumor-agnostic therapies have been approved in the EU and the US and which biomarkers they target? You have 90 seconds available for this answer.
Super. So we have at the moment 3 NTRK or TRK inhibitors, namely larotrectinib, entrectinib, and repotrectinib. These target NTRK gene fusions, exceptionally rare. Between 0.3 and 1% of cancers have such a fusion event. But it was the first targeted agent or the first target that was approved with a targeted small molecule. Then we have pembrolizumab, an immunotherapeutic, which is approved for microsatellite high or DMMR positive cancers and also for cancers that have high tumor mutational burden. In the DMMR space, we also have the immunotherapeutic dostarlimab. Then, and Vivek Subbiah was really instrumental in bringing this combination into approval with dabrafenib and trametinib for BRAF V600E positive cancers, excluding colorectal cancer. And then we have selpercatinib. Again, Vivek played a pivotal role for RET gene fusion positive cancers. Also a rare molecular alteration, but not as rare as NTRK fusions. And the last approval was trastuzumab deruxtecan for HER2 3+ positive cancers.
Wow. Thank you for that amazing and comprehensive list. So as you said, NTRK are picking needles in haystacks. And we have not one, not two, but 3 different NTRK inhibitors currently approved. And the latest is repotrectinib in the EU and the US. Could you please describe the key data that led to the approval of repotrectinib?
So repotrectinib, the pivotal trial was TRIDENT-1, which was a phase 1/2 clinical trial. And as I said, NTRK fusions are exceptionally rare. So finding such a patient is great. But as with all targeted treatments, there is resistance to first-generation TRK inhibitors. And this is exactly where repotrectinib has its specific role. Not saying that you can't use it in other situations, but in TRIDENT-1, a significant proportion of patients, almost 70, had been treated with a TRK inhibitor before, and the response rate was still almost 50%, and the median progression-free survival was longer than 7 months. So this is really why repotrectinib is an important option, because it can be used in patients that have progressed on another TRK inhibitor. In terms of safety, no new safety signals that would concern us too badly. So although, as Vivek said, a needle in a haystack, an important option for patients with TRK fusion positive cancers.
That was a great review of comprehensive data. So Ben, what about the clinical data that led to the approval of TDXD? 120 seconds available for you here, as this is an important ADC that provides a large group of patients option for targeted therapy.
Yeah, so as you pointed out, Vivek, this is the first ADC to be approved in a tumor-agnostic fashion. And to my knowledge, it's the only ADC where you actually have a biomarker that predicts response to this. We, as the oncology community, know TDX well for its use in breast cancer or in gastric cancer. And the pivotal trials that I want to cover that led to the expansion of the label for TDXD in HER2 3 plus cancers were Destiny Pan-Tumor 02, Destiny Lung 01, and Destiny CRC 02. TDX was given at 5.4 milligram per kilogram once every 3 weeks, so nothing new here. And overall, the overall response rate was 37%. But then looking more specifically, with central HER2 immunohistochemistry in patients with IHC 3+, the overall response rate rose to 61.3%. And this is especially important because this was not only seen in cancers that have a lot of different options, but also in hard to treat cancers such as biliary tract cancers. And this was a group of patients that had received 2 or more therapies before enrolling into the Destiny trial landscape. So this is an option for a large group of patients. Importantly, in these 3 trials, no new safety signals. As always, when we're talking trastuzumab deruxtecan, we have to be wary of the ILD pneumonitis. But as these drugs have been around for quite some time, or this drug has been around for quite some time, and we know to manage it, I believe this is nothing that would prevent us from using TDXD in patients with HER2 3 plus cancers. So now we're turning the tide here, Vivek. It's my turn to ask you questions. I want to focus now on HER2 as a biomarker. Why is HER2 testing different when compared to testing for biomarkers such as an NTRK fusion or BRAF V600E? I'll put you on the spot. 30 seconds for you.
As you said, HER2 is one of the most exciting developments in precision oncology right now. HER2 protein expression is measured as opposed to genomic alteration here. This is measured using IHC, which is immunohistochemistry, with reflex ISH. And this is scored by a pathologist. So this IHC is an additional test needed alongside a comprehensive NGS for patients.
Super. What would you say are the challenges that oncologists face with biomarker testing across tumor types? This is a complex question. So you have 90 seconds. Please move ahead.
So my personal opinion is that the fundamental problem is this: the entire infrastructure of oncology was built around tissue of origin and tumor types. And now we are trying to retrofit precision oncology into a system that was originally never designed for it. Number 1, assay heterogeneity. HER2, PD-L1, NTRK, TMB each require a different platform, different cutoff, different interpretation frameworks. So most of these thresholds, for instance, in HER2, have been validated in breast cancer and gastric cancer, and we are working to extrapolate them in pan-cancer approach. Number 2, second is access. The patients who benefit most from tumor-agnostic testing, rare cancers, cancer of unknown primaries, are exactly the patients that are least likely to get tested. Number 3 is tissue adequacy. Small biopsies, low tumor cellularity, again, decalcified bone samples. These fail NGS runs regularly. And when the biopsy fails, the molecular opportunity here is lost. Finally, the most important aspect is reimbursement. As we all know, coverage is completely inconsistent, especially for tumor-agnostic indications outside the traditional settings. The policy has not caught up to the science. Until we have an alignment of all these, we'll keep leaving the molecular matches on the table, And that means patients who could benefit from these precision medicines don't.
I couldn't agree more, Vivek. And I believe this is why such educational activities are so important. Tumor-agnostic therapeutics, it's their nature that there are for every cancer patient. Yes, these genomic alterations in itself are rare, but we now have, as we've shown, different drugs being approved. So if you add up a couple of percentages here and there, you end up with a significant number of patients being positive for one on the other biomarker. So by just randomly testing and not testing comprehensively, you will miss out on a lot of patients. So it is important that we take this message that there are options and patients should be tested out to everyone and make this known. I believe this is another important message to build what Stacey Gray once coined genomic or molecular confidence in our community. So another shorter question now, given the challenges we've just mentioned, what information and guidelines are available to help guide biomarker testing for clinicians? You got 60 seconds.
The good news is that the field has responded with real actionable frameworks. ESMO has been particularly rigorous here. Again, as you know, Dr. Ben is the chair of the Precision Oncology Task Force. This group has developed a SCAT scoring system. It ranks the molecular targets by strength of the clinical evidence, so oncologists aren't guessing which alterations are actionable and which is nice. And in 2024, ESMO published dedicated recommendations on clinical reporting of genomic test results for solid cancers. And again, I think this is a landmark document that brings standardization on how sequencing results are interpreted, most importantly, communicated. On the other side of the Atlantic in the US here, NCCN, the National Comprehensive Cancer Network, offers two complementary resources. The Biomarker Compendium, which consolidates all testing recommendations across targets, and tumor-specific NCCN guidelines, which embed these biomarker testing algorithms and frameworks directly into each cancer type pathway.
Absolutely right. I'll stop the clock here. So we've discussed a lot of challenges. How could clinical practice workflows be adapted to identify patients who would benefit from treatment with tumor-agnostic therapies, and then to deliver the most suitable therapies to these patients?
Thank you so much for that great question. And as we spoke about this, the ESMO 2024 recommendations gives us, I think, a clear blueprint. First shift is reflexive. Upfront molecular testing, not testing as a last resort in the last line of treatment. That means comprehensive genomic profiling built into the diagnostic pathway at the point of tissue acquisition. The biopsy and the molecular workup should happen in parallel, not sequentially. Second, genomic results need to be reported in a standardized, clinically actionable format, not a raw variant list that lands in a portal, but structured reporting that flags tumor-agnostic targets explicitly for clinicians. Maybe even going another layer, adding SCAT-ranked evidence so that oncologists, the clinician, the busy clinician, knows immediately what's actionable. Finally, I think this is critical. As you know, you've spearheaded this entire MTB, molecular tumor boards. I personally feel that molecular tumor boards need to be embedded in routine care, not reserved for complex, refractory, or extremely rare cancers.
Thank you very much. I believe one additional point I want to make in order to build confidence around these drugs that have largely been used in later stage cancer patients, and we then see still significant activity. One would imagine that you would see even better activity in earlier stages. I believe here real world evidence and post-approval registries could really help to build confidence that these are not just drugs that you should use, as you said, after exceeding all standard, or I'm not saying standard options, but all options. You can always give a little bit of Taxol in the end, and we should hope for a silver bullet, but really use them smartly as a clinician when you think this is really the best option. pathologists have always been very important. Pathology is one of the foundations of medicine. But in precision medicine, in precision cancer medicine, it is extremely important to have them as integral parts of our treatment teams or management teams. How can we facilitate interaction with our friends in pathology so that we really achieve the best benefits for our patients?
I personally think this is fundamental. Pathologists are precision oncology partners, not diagnostic support alone. I say our friends are precision oncology co-pilots, and we oncologists cannot fly solo here. The collaboration has to start before the biopsy report lands. The oncologists need to share clinical context upfront, what we are looking for, what's actionable for this patient, and what test do we actually need. That conversation shapes what gets ordered and how the results are interpreted. Then we have to close the loop on the other end, review results together. Not a note in the portal, I would say a real conversation here, because a HER2 IHC2 plus in a biliary tract cancer means something different than in breast cancer. I think that nuance lives at the intersection of pathology and oncology. That's an important conversation. So how do we implement that, right? We are all busy people. MTBs. I would say molecular tumor boards are the gold standard for making this systematic, not just for complex cases, but has to be embedded in routine care. When oncologists and pathologists operate in silos, patients fall through the cracks. When they function as co-pilots, the right test gets ordered, right test gets interpreted correctly, and translated into a treatment decision faster.
Absolutely. And I believe that this trusted relationship is, as you pointed out, pivotal. And I believe it goes both ways. You know, you come home from AACR, you come home from ESMO or ASCO, and you know that a new biomarker is on the rise. And you go straight to your colleagues in pathology and say, I now need MET IHC or MET FISH because we're going to see MET ADCs coming into the arena quite soon. The other way around. So you want a new test being implemented and your pathologist says, well, we have this, but I would assume that other capacities are needed. So I would say we expand to another testing algorithm rather soon. So this dialogue really, as you said, co-piloting this complex biomarker landscape is going to be absolutely critical.
Dr. Benedict Westphalen, we are officially out of time. I think this has been a great discussion and a lot of fun. Thank you so much for joining me today. And thank you for participating in this activity. Please continue on to answer the questions that follow, and please complete the evaluation.
Thanks a lot also from my side, Vivek. That was a lot of fun.